Welcome to Nipton Talks. It's Dr. Ashley Robey, and with me is Dr. Killeen. Kelly, good to
Hi.
see you, as
Nice to
always.
see you.
And this episode, we're talking a little bit about difficult patients. I was almost hesitant to do the subject because it's even tough to talk about. I had an anesthesiologist friend that was telling me the other day how a patient came up to him and asked, "Oh, do you love your job?" And he just answered, like it's okay. I thought, oh man, that's unfortunate because in general, I really do feel that I do love my job. There are obviously certain parts of it that are more challenging than others, like, the surgery centers taking away your block time, or one staff member not getting along with another staff member, having to wrangle that. But one of the most challenging parts is the difficult patient part. So I thought it would be interesting for you and I to talk about our experiences with that. So beneficial for other surgeons and physicians, but for those patients out there that maybe have some more introspection, identifying yourself as a difficult patient would be helpful so that you could figure out ways to be less difficult, because for surgeons, physicians in general, dealing with difficult patients is difficult, hence the name.
Hence the name. Yeah, and I think it's important to note, if you're a patient that's listening to this, we're not saying all patients that are difficult. A very small percentage of the people we care for cause us trouble. And we're also not saying that doctors aren't difficult assholes, gaslight patients, all of those things. The
Oh
topic
yeah.
today is just identifying patients that can be difficult in your practice. And we are not talking about doctors today. That is for another episode. But if it's
Yeah, we could
upsetting
do a
for
difficult
you,
doctors podcast for sure.
right. Yeah. It's always, sometimes some things are just not for you. And if it's upsetting to you and you don't want to hear it, then don't listen.
Sure. The thought behind this podcast isn't to dog patients out or say that everyone's difficult. Like you said, I think that is the minority of people. But there was one article in the Journal of Internal Medicine that said that difficult patients actually represent about 15% of people that physicians see. So 1 out of 6. I feel like it should be lower, but maybe it's just my ability to kind of let things roll off my shoulder. Yeah, 1 in 6 sounds high. I would have guessed more like 1 in 8 or 1 in 9. So what a difficult patient is, well, let's talk about the ideal patient. So the ideal patient is someone that, comes in, they want to do something, they have realistic goals. Let's, for us, we're surgeons. So let's say they have their surgery, they do the things that you want them to do post-operatively. They have a good outcome and they're thankful and you're happy, and yay, that's the story. So any deviation from that storyline can present itself as suboptimal. So being a difficult patient would certainly put you at increased risk from deviation from the ideal scenario. So we wanted to cover some of the typical kinds of patients that would be considered difficult. And when researching and thinking about this podcast, it was interesting because the 4 categories that have been discussed quite a bit in the literature, I don't know if my practice or what I've experienced specifically lines up with those 4 subtypes of patients. So those are and we can talk about those in more detail, but that's like the dependent clingers,
Mm-hmm.
the entitled demanders, the manipulative help rejectors, and then the self-destructive deniers. Now, I can certainly think of examples of those type of patients, but in the field of plastic surgery, where I would say like classically we're seeing like pretty healthy patients, there are certain subsections of difficult patients that I don't think we would see as much, just because of the nature of our client base. And both of you and I do more like, well, you do some reconstructive, but more like cosmetic recon, right? Are you still doing breast cancer?
I do breast cancer. Yeah. Breast cancer, colon cancer patients. Mm-hmm.
So your practice is obviously different than mine, but most of what I see are patients that are electing to do things that don't specifically have to do them. I guess you could make an argument that a cancer patient doesn't have to undergo reconstruction, but a lot of them kind of do to some extent. They have to
Right.
do something to fix what was taken out. So the first category, the dependent clingers, that's the group of patients that feel like they have a need for love and they need to have attention. And for example, things like they will call your office 4 or 5 times a day, asking new questions, same kinds of questions that you've already answered over and over, that have probably been discussed during the consult, during the pre-op and post-ops on your paperwork. They just need that. They need that reassurance. So
These are the ones that I always say they use the hospital or the office texting or email service as their personal journal. These are the
yeah.
patients where you wake up and there's about 25 paragraphs daily for weeks of every little thing they notice, every complaint they have. And like you said, it's often things that they've already discussed with you multiple times, and it can be very exhausting for the staff, especially when we have a very high patient load. We may have 15, 20 patients minimum that each staff member is managing throughout the day. And it's difficult when you have a patient who has all of these complaints. And the thing that always worries me about these patients is because they're so in need of constant high level attention, that the staff members become burnt out by them. And then I'm always concerned things are going to be missed because, you know, they send so much information during the day that if there is something different, alarming or worrisome, that it will be lost in the paragraphs and paragraphs and the many, many calls. And that's always my concern with these patients. So I always tell my staff that I find these ones one of the scariest forms of difficult patients, even though they're not mean or
right.
hateful. I do find that this patient is the classic patient that has serious things missed.
Yeah, I think you're right. It's kind of a cry wolf scenario where they're like, oh, this is a big problem. Oh, there's a spot that looks like it's a little pink.
Mm-hmm.
Then the next day it's something else. And the next day it's something else. And, you know, you're going through the motions and looking at photos and talking to them. And by
Right.
the 10th day, the office staff that's usually fielding frontline these concerns gets really exhausted. And if an issue does come up that is concerning, they're more likely to be like, okay, well, the first 10 times it was a big nothing burger, so it's probably fine. And, you know, that's probably true most of the time, but there are cases when it could be something that really needs attention.
And these are often patients without good support systems at home. Even if they're married or have a friend or family member caring for them, it's often not a friend or family member that's engaged and helpful. And this is a kind of crying out for help type personality. And like I said, they can be not only exhausting for the staff and a lot of work, but they're also high risk for problems being missed.
Yeah, I had a patient who this made me laugh. Actually, it was super annoying, but in retrospect, it makes me laugh. She called the emergency line, you know, the after hours line. It's like 9 p.m. Like, I don't have, I need to have a question about when I can shower. I'm like, oh, you didn't get your post-operative instructions. It has all that written out. Yeah, I did. They're just downstairs. And it was just going to be easier for me to, you know, have you paged than, you know, to get them or to have someone in my family get them. So here I am.
It's hard because I think too, as a patient, sometimes you forget that your doctor has surgery at 7 a.m. the next day. And just like it was important for me to be at my best for your surgery, I need to be at my best for every patient going forward surgery. And things that don't need to happen at night don't need to happen at night.
Yeah. And, you know, we also have families and lives outside of our work as well. As a rule of thumb, I would much rather hear about something that wasn't anything and be able to reassure the patient than to not hear about something that was concerning. And I'm sure you feel the same way, but those scenarios where like, yeah, you know, just walking downstairs, wasn't feeling it. Yeah, that's a difficult patient.
Or ask for appointment times. I've had that
Oh
several
yeah.
times. They'll call
Yeah.
at midnight, 1 a.m. And they'll be like, hey, I think I have an appointment this week. When is it? Like, 1 a.m. the right time to wake your doctor?
Or have you been called like for directions, like at like 5 a.m. for like a surgery center?
Yeah.
Yeah. I don't know how to get there. Did you type it into your map software? No, I just, you know, I thought you'd lead me the way. I'm sure we've all had ridiculous phone calls. They are few and far between, but some of them are pretty memorable. Okay,
Yeah.
so the next type of difficult patient is the entitled demander. And those are the patients who are insecure, they have a fear of dependency, and they will attack their physician in order to reduce the physician's power over them. So sometimes a doctor can be tempted to counterattack, but they should try to resist that temptation. Do you feel like this is a kind of person that you've encountered?
I think we see this type a decent amount in plastic surgery. There is a center in town that actually works with body dysmorphic patients, and they were coming giving a lecture to my staff because body dysmorphia is common in plastic surgery offices, and we just want we want to give our staff the tools to recognize this.
15%.
15%. And this psychologist that came and spoke to us, this was a couple of years ago, talked about this particular patient type and said that in particular, these patients often have a little cluster B pathology, and narcissism is very common in this patient type. And they are dangerous. They can be both physically dangerous, but they can be hostile and very difficult. And he gave us some tools to recognize these patients. And one of the things is, he said, is very true. What you're saying is that there's always a power dynamic with them where they want to be on top. And so if you encounter that in a consult where it's almost like they're trying to one up you, they ask the question, you answer, then they one up you with another answer. But one of the things that I thought was really interesting is he said that these types of patients are often enamored with the fame of people that have cared for them prior. So this is the classic patient who's like, well, my last surgery was with very famous surgeon here. My last surgery was with this very famous person. And they're very enamored, like it kind of builds up that ego for them to tell you about all the very famous people that have cared for them. And it's interesting, I've used that in consults. I've actually encountered this now, and I recognize it after he pointed it out. And it's helped me weed out some of those patients, because those patients, in his opinion and his practice, are the most toxic patients for physicians of all types to take on. And obviously for non-elective things, guys, we're not talking, you can't say no to any patient, but as we are able to choose our patients in an elective manner, you want to choose people you're going to have a good relationship with. And this is a patient that can be extremely hard on both the staff and the surgeon.
Yes, for sure. And I will say this, that looking for those warning signs, looking for clues that this person could be a difficult patient is super important. And it's very helpful for me, and it's helpful for you to know that beforehand. But a lot of people have the ability to hide it
They do.
reasonably well.
They do. I mean, we've all been tricked by people that seemed completely reasonable, and then post-op,
Post-op, they just let it go. They're just
yeah.
like, I'm not hiding anymore, and I'm going to go crazy. So my perfect example of this patient is this lady who I thought seemed totally reasonable. She had an abdominoplasty. Everything went great. I did notice intraoperatively that she had a ventral hernia, small ventral hernia. Obviously, prior to the diastasis repair, I fixed the hernia. Nothing weird, nothing unusual. But when I saw her on her first post-operative appointment, she was like furious. She was irate. Primarily because she had found that I had fixed her hernia. And so I told her that it would be worse for me to just look at the hernia and not fix it. And it didn't really impact her recovery. She still has the same restrictions. It shouldn't really affect her ability to return to work. And that's what she was mostly upset about, that she referenced, she's like, have you been to webmd.com? Have you been to Tufts University? Well, they do not agree with what you're telling me, that it takes a lot longer to heal now that I've had a hernia repair. And I told her that, that just isn't the case. And she even said, well, I noticed on your website that you don't advertise that you do hernias. So is that because you're just not a hernia expert? I'm like, yes. I'm not like, come all ye with hernias to my practice. I want to do your hernias. But certainly it's appropriate with a hernia in the middle of your field being exposed to consider its repair. That's a disservice to not repair it. The other funny part was that she said, well, and why did the surgery take 2 hours longer than scheduled? And I said, no, it was close. She's like, no, it was 2 hours longer. My mom was in the waiting room, and she may be old, but she knows how to tell time. And so I'm like, okay. So I pulled up the operative report, and it has, time in the room, time out. I'm like, well, it looks like we're literally within like 2-3 minutes of the guesstimated time, which is pretty spot on. Like, it's hard to get any more close than that.
Right.
And she's like, well, I mean, you could have just made that up. You could have falsified that. I'm like, so I'm preemptively falsifying records because I think you might come in and accuse me of doing 2 free hours of surgery without getting paid.
I know sometimes when patients are upset about something, it stops being about what they're upset about, and they're just upset. And so instead of, especially if they've decided they want to be mad at you, there's no way you can get out of that situation. And so it moves from being mad about one thing to everything surrounding the surgery.
Yeah, everything.
The staff was bad, your coordinator was mean, the post-op nurse kicked them out too far. And it stops being about what the actual question was that they had. Like, the question is, As a patient, if you leave the operating room and you find out something was done that you weren't expecting, I always think, and this is a good way to be in life in general, is just assume positive intent. If you go to assuming negative intent, that's a negative relationship with your surgeon and anyone in your life. I always use this example. If your husband comes home late unexpectedly, if you wait at the door and start screaming at him for cheating on you, that is not a good relationship. But hey, why were you late? And he says, God, there was an accident on Benedict on the way home, then that is a healthy relationship. And I think sometimes when patients don't have really good communication skills and they've built themselves up to this level of fever pitch where they've decided something was done wrong, they lose the ability, and I think it's not just patients, it's us too, they lose the ability to have a healthy conversation. So I always say, my advice is always, if you have a question, assume positive intent at first and come to your doctor or your surgeon with questions and get those questions answered. And if you don't allow that, then you run the risk of it snowballing into this everything is wrong phase. And it affects how you heal. It affects how you feel about your surgery. It's just a very toxic, negative vortex. And if you can get yourself out of that, that's the best thing for you as a patient.
Yeah, I agree. I think in those scenarios, from the perspective of the surgeon, it's interesting because when you encounter something like slightly, which honestly, having a little hernia with an abdominoplasty, I have to say, isn't that strange? Like, it's fairly commonplace.
That happens all the time. Yeah.
And so it's weird because the truth is that most people are like, oh, thank you.
Right.
Oh, you found that? Oh, thank you for fixing it. So having this outlier patient being so upset and so put out and so angry on so many levels, it is unexpected.
And it's sometimes too just a function of they were not totally awake when they heard things and it got twisted and they were confused and they were in pain. Sure. And maybe their caregiver, her mom's complained to her about it taking too long, and then it just allowed the whole thing to snowball. So again, I think the smartest thing to do as a patient is, if something is unexpected and you're worried, immediately call. Don't wait a week to your 1-week appointment and allow it to snowball and get crazier and crazier in your head. Call immediately and say, hey, I have some questions, and we're always happy to answer.
Yeah, I think that's true. So next category is the manipulative help rejector. So those are the hypochondriacs. They are pessimistic and have little hope of recovery. They often crave attention or fear it, and this can lead to contradictory behavior. So they're doing things that are the opposite of helpful to them. What this made me think of was a scenario where I had a patient who had an abdominoplasty, and she had a breast aug, and she had a breast lift. And honestly, everything went great. And I saw her post-operatively, and it looked good. And then she called, so it was like 2 weeks out, and she called at 3 weeks, and she's like, okay, this little spot, it's opening up. And then she came again, oh, the spot's worse. And so it became a progressive wound issue. So the wounds are not getting better, they're getting worse. And for a plastic surgeon, that's certainly, it's curious because classically wounds slowly improve over time unless something else is at play.
Right, right.
And I'm always going over the things that, okay, what are the things that a patient can control, right? They can control their nutrition. They can make sure they get high quality food, an adequate number of calories, so classically a little bit more than baseline. They're getting enough sleep. They are trying to manage stress, those kinds of things, adequate protein intake. So this lady, I don't know, I think she's coming in on a regular basis. Every time I see her, her wounds get worse. Oh, are you doing this? Are you doing that? Yes, yes, yes. So they're doing everything perfect. And I still remember the husband, he would come in with her and he would be upset. I feel like every visit he would also get more and more upset. She was more upset. She was crying. And I remember him yelling at me. He's like, Robey, you better fix this. And it was just super aggressive, almost threatening. Like, if I didn't fix this, he's gonna, F me up.
Right.
Um,
Which is scary.
Yeah, he was kind of a big guy too. And finally, and I can't remember the details of exactly how it finally came about, but it came to my attention that she actually wasn't eating, and that she had only been eating like 1 egg a day, or, something ridiculous where it's like 60 calories. And so that's why everything fell apart. She was wanting to lose more weight. So yeah, that reminded me of this manipulative help rejector, because She made a point of coming in, saying how she's doing everything perfect. I gave her a piece of advice after piece of advice as to how, she and I could make these incisions heal better. When in fact, she wasn't doing those things. She said she was. It was getting worse. And then she would be emotionally volatile and her husband would yell at me. So
Yes.
it was a really difficult patient. Once she finally admitted that, okay, yeah, I was actually starving myself, her incisions rapidly healed as soon as she started eating, like obviously.
These patients can be really frustrating. I mean, I've had a few of these in recent years, and they also tend to use whatever system you have as their personal journal, but they don't accept any help. So instead of just flight of ideas concerns, they perseverate around the same things and they're seemingly incapable of moving forward. It's like they're stuck in this vortex of discussing the same problem, but no ability to move past it. Like you have a breast wound after a breast reduction. We've told you 400 times what to do, and then none of that is done, but still wanting to discuss it. Or the patient that's unhappy with their implant size. They come back and they want to discuss it over and over again. There's no ability to change what's happened. So you give them options. You talk about, hey, we can do this, that, and the other thing. No desire to move forward, just in this vortex, wanting to come in and sit in this unhappy feeling they have. And, we hate when complications happen or a patient's dissatisfied with their outcome, but at a certain point, we cannot go back. And it's incredibly unhealthy to sit and perseverate on something we can't do, to go, well, it should have been, could have been, would have been, maybe, what could have been different. It doesn't matter. It doesn't matter what could have been different. It's not different. What is happening is the reality in the situation, and we can only move forward. And if you're not accepting advice, and the continued desire to come talk, again, it's very manipulative, just like the description is. It's getting a lot of attention from the staff, and it turns into a very hostile relationship often, because every member of the staff gets very frustrated because it doesn't feel good when someone doesn't listen to your advice. When they come to you, they take large amounts of time, you're trying your best to help them, and they not only don't listen to you, they come back and force you into the same conversation a few weeks later. And so it creates this very toxic relationship.
Exhausting.
It's exhausting, and it often devolves into something ugly, and it's very hard. So with these patients, I often have found the best way to manage that type of patient is to tell them exactly what I just said. I cannot change what's already happened. I can only do what's happening in this moment. So can you move forward with me? Because you and I cannot move back. And if you cannot move forward with me, we need to find you a doctor you can trust so you can move forward with someone. And then sometimes when I phrase it in that way, they kind of realize that no, they do want me as their doctor. Sometimes I don't think they always know they're in that vortex. It's a really hard place to get out of. I think often these are patients that have histories of depression, and it's very easy to get pulled into a dark place. But yeah, it's very toxic and hostile. And these patients also can be scary, like your patient's husband was threatening you.
Yeah. Well, certainly knowing the patient is rejecting your help, I think sometimes I do know, right? And that's a scenario where you can have these very upfront conversations like, hey, I'm giving you recommendation A, B, and C. I see that you want to do not even any of them, and you're so frustrated and you still want to talk about how can things change.
Correct.
But it's especially difficult when you say, let's do A, B, and C, and they're like, yeah, I'm doing it, and they are doing none of it.
Right.
Because you're left totally in the dark as the physician, right? And I just, you assume that you have the same goal, that you both want good outcomes, that you're working with the same truth to get to that a desirable outcome. But when you have part of that equation being, okay, the patient isn't telling you the truth and you're trying to make clinical decisions based off of lies, it's really tough. It's
Yeah.
really
It's hard. It's hard. And it's supposed to be, they always say shared decision making, but it's really hard because it's really not. The patients decide what they do and how they do it. We can give all the advice we want, but sometimes we just don't have a team member who's engaged with us, and that makes it complicated.
Yeah. So, I mean, I can come to terms with people saying, look, I don't like one of those recommendations and I'm not going to do it.
Right.
I do appreciate them being upfront with me. That way, at least I know what they are and are not doing. But yeah, when you're left not even knowing what's going on, but it still being expected to solve problems, it's really dangerous, actually. So
Yes. Absolutely.
Okay, next category are the self-destructive deniers. So this has been described as a patient who's practicing a form of chronic suicide. I don't really feel like this is a patient I see a lot. The examples they give are like the incurable alcoholic or the non-compliant diabetic. But one patient that did make me think of this kind of patient a little bit was I had this older guy that came in for a consultation. I think he was mid-70s, and he wanted to have his nose done. And he had a list of health problems that was, longer than my arm.
Right.
And he's hyper focused on this issue. And I look at his health problems like, well, I see you have lung issues and your heart's not great and your kidneys, you've had renal failure. I think the nose and that prioritization list falls pretty low. It's like heart, lungs, brain, kidneys, liver. Nose, as far as aesthetics, it's at the bottom. And this patient said that he didn't care. His goal was to look good in his casket, and he didn't care if he died on the table as long as his nose looked good. I didn't operate on this patient because that's not a good candidate, but I can't say that's the only time I've seen someone like that, where they're hyper focused on one area, and it's probably a little bit of that body dysmorphic issue, and all their other health problems be damned, and they don't care. At least this particular patient was upfront about his list of health problems. I've had patients that will they'll just not include that. They just won't
Right.
talk about their health problems. And that gets back to the same kind of scenario we're talking about before, where the physician is trying to make medical decisions and risk stratify patients while you're working without the truth, without the full set of data. Again,
A version of this that we see in plastic surgery that's a bit less dramatic is these patients that have kind of compulsive repeated surgeries. So the people that they have a surgery a year, and I know you've seen these patients, they have their breasts redone every other year for 20 years. They have multiple revisions of their tummy tuck, multiple revisions of things to their own detriment. And the reality, unfortunately, is that if you wave a credit card around, plastic surgeons somewhere will grab it. And I think
I
if
tell
you are,
people that, yeah.
yeah, and if you are the one that grabs it, this is the type of patient that patient always is, because anyone who's had that many surgeries, often if you talk to them, the outcomes get worse and worse and worse. I always tell people, think of Michael Jackson's nose, right? They didn't know when to say when, and he eventually necrosed the tip of his nose. And I think that is the type of patient, but they still push for more even after things happen. It often becomes toxic and hostile. The only saving grace, though, as a doctor caring for that type of patient, if you make that mistake, is that they will drop you and move on very quickly. So they don't often stay with the same surgeon. If you talk to them, they've seen everybody all over the world 15 times over, and they'll have one surgery with you. And even if it turns out beautiful, they move on. But they can be very difficult in the post-op period because they don't have reachable expectations. And the surgery is more of a compulsion than it is really something that they really wanted or needed.
I would say for those patients that, again, for example, have had 6 breast surgeries or 4 abdominoplasties, they often have lots of scars. There's things that could potentially be improved, but you have to wonder, is doing another surgery, completely revising everything, going to be worth it? And I think
Right.
there probably are some scenarios where you could make an argument that I could make this better, but oftentimes it's just hard to justify, right?
Yeah, I mean, there's a chance you could make things better, but there's a bigger chance you could make things worse. And so, it's always risk benefit ratio, and we're not doing the right thing as surgeons if we are guiding people to things that are likely going to end up worse. But like I said, waving the credit card around is sometimes enough motivation for people to take on this type of patient, and then they will regret it.
Yeah, I say that even though I don't think you're a good candidate, I know that you could find someone that would do this. I would just caution you that you should still not do it. Like, you'll find someone. There's someone that'll be like, yeah, let's go for it. But
Yeah.
doesn't mean you should. Just because you
Right.
can doesn't mean you should. Some other categories that I see quite a bit of, and they definitely can fall into that difficult patient category, would be like the classic unrealistic expectations patient. So the patient that is 30, 40 pounds overweight, has an apple-shaped body, and is showing you photos of bikini models, right?
Right.
They have tons of visceral fat, and they're like, I want to look like her.
Well,
If
it's
they're
not
that,
just physical, it's when they think that the surgery is going to do something not objective. I've had patients will tell me that, will be very upset because the surgery didn't make them want to exercise. They thought smaller breasts would make them want to exercise, or they thought smaller breasts or changed breasts would somehow salvage a relationship in their life. And then they're very upset because it didn't. And that's one of the hardest things, because patients don't often tell you those things before surgery. You know, you spend time talking about the objective because that's what we can do and give. But in the patient's head, they have a bunch of subjective goals that they don't necessarily tell you. And then when those goals are not met post-op, it doesn't matter how beautiful their reduction lift tummy tuck turned out. If their life didn't change in the way they wanted, then it's your fault as a surgeon. And that is a very hard patient to manage. And they, again, can be very hostile and upset. And it often, they don't want to take on any of the, and I understand why. I don't think I want to either. We never want to take on the responsibility of things that may not be perfect in our lives. But you become an easy target as the blame. You know, they paid lots of money to you, and look, their life isn't better in the way that they thought. And I think that is a really hard patient to manage. And I still don't know quite how to manage those people. And I've tried to ask more questions in the consult and, you know, weasel my way into more kind of social information and not just the objective medical information. But like I said, these are often things they're insecure about, so they don't mention it to you. And you just have to be very mindful of what's going on when a patient's not happy and they look beautiful, because it's often this type of thing, this type of unrealistic expectation.
Yeah, you're right. There are patients that will clue you into these kinds of things preoperatively, and classically that is a big deterrent for a surgeon. I remember I had a patient who she wanted a revision abdominoplasty, and the reason why she wasn't promoted to manager at her current place of employment per her was because of her previous abdominoplasty results. So, you know, when you hear things like that, I mean, that's obviously a red flag, and you know that, okay, the reason why your life isn't where you feel like it should be has nothing to do with your old abdominoplasty scar, right? And I can tell that even if I fix it and it looks awesome, your life is not going to be an order of magnitude better. But then there are patients that don't tell you. I remember several years ago, I had a lady, I was just doing some kind of routine breast work on her. And I was standing there as she's being induced for her anesthetic, and they take the mask off, and she said, because she was saying something, and they're like, what? And she's like, I really hope this fixes my marriage. And I was like, what? No, oh my God. I'm like, no.
Yeah, it won't. It never does. Just like babies don't fix marriages, cosmetic surgeries don't either.
No,
Yeah.
it was awful. I mean, her breasts look great. I don't know what happened with her marriage, but I'm guessing this is probably not better.
Yeah. I know it's hard too. And I can often tell there's trouble in paradise. And I have patients that I worry about this. When you go and talk to them, after surgery, you go talk to the husband in the waiting room. There's just a certain husband behavior that I have identified as a risk factor. And I always tell my nurse practitioner, this is one that needs extra support, because I'm worried that not only is he not going to take good care of her, that there's a lot more trouble in this relationship than they let on. And it's, like I said, it's hard.
Yeah, when husbands have very specific preferences, I feel like that's a red flag, where they want it to look exactly like this or like that, and they'll show you photos of their ideals. That's actually pretty atypical. What I like to hear as a surgeon is a husband is like, oh, I just love you how you are, but I support you. I mean, that's what you want to hear.
Whatever you want, I'm just here for you. But yeah, the ones that I also think are worrisome is the ones that are annoyed to take care of them afterwards. They're annoyed to drive them to appointment. They're annoyed to be there picking them up. They don't want to manage the drains. You know, there's just a lot of, like, you can tell they just don't want to be part of that. And I think that's not a good place to be. That's not a good relationship.
Another category that I think I see a fair amount would just be like the classic deceitful patient. And I know that you and we've already kind of touched on that. It's the person that is just wanting to tell you what they want you to know, right? They want to paint a different picture than what the reality is, because they think that, I'm guessing that you as a surgeon will think that they're a better candidate, or you'll be more likely to do their surgery. I mean, I think that's the primary motivation. And I get why, because oftentimes when I hear about the truth after the fact, I'm like, oh, wow, yeah, I probably wouldn't have done their surgery. but
Right.
it doesn't make it right. It's still very dangerous.
It's the patients that don't want to share their medical records with you.
Yes.
They don't want you to see their prior op report. They don't
Right.
want you to know what happened at a prior hospital admission. And they don't just say that. There's always a reason. They'll
It's
say
like,
like,
oh,
oh, you
they were a
found this.
jerk and I don't want to talk to their office or
Yeah, or they often will say, I don't know who the surgeon was, things like that. I can't remember. I called and they don't have records anymore. There's a lot of that behavior. And as a physician, we don't have the ability to request records or get them without a patient's opinion. So we are like, if a patient tells me this is what happened on that hospital admission, I believe them because they are my patient and I have to believe what they're telling me. And if they're being deceitful and dishonest, it compromises their care. It makes a dangerous situation where they could potentially be harmed.
Sure. This is a bizarre story, but I had a patient who was from out of state that had liposuction. She was just doing liposuction. I saw her in consultation. She had surgery, and I got a call. I was actually in the OR with her, and I got a call from the front desk of the surgery center saying husband wants to know how much longer her consultation is going to be. It's already been 2 hours.
Oh God.
So he drove her, he had no idea that she was having surgery. He thought she was there for a consult. Um, I post-operatively, it gets even weirder. She sent me photos and called the emergency line. She was like, I'm bleeding everywhere. Like, well, that's not very common, like bleeding out of your 1 centimeter incision holes. Let me see a picture of what your garment looks like. Because I put her into, she actually had a tan garment. Thank goodness for that. But I otherwise hate tan garments. And you could see this like super clear kind of serous drainage around where her incision sites were. So she probably seeped a little bit of fluid. But then she took pictures of bloody towels on her floor. So she's got like serous fluid near the incision,
Right.
but dark blood on the floor. I'm like, well, how did that happen? So the garment's totally fine, not dark, but then you've got dark blood on the floor. That's concerning. I'm like, that's coming out of your incisions? Yes. Okay, well, you need to go to the ER. And if you're bleeding that much, like don't drive yourself. You need to have someone drive you. And so I call her back and she's in the ER and she's like, oh yeah, they're just checking me in. Actually, they're walking in right now. I gotta go. And so before she hung up, I was like, what ER are you in? So I can follow up. But she told me a name. And I didn't hear from her for several hours. And I ended up calling the ER, asking to follow up on this patient. I'm like, oh yeah. Yeah, we haven't seen her in 6 years. She's not here. She hasn't been here.
Wow. That's not nice.
So my guess is that she's just showing me photos of menstrual blood on the floor.
I haven't had one that was that dishonest, but I do have people that sound alarms frequently when
Right.
nothing's happening. And I have just found that if you think that's happening with a patient, again, you don't want to miss anything, but also this is kind of a treatment for that behavior is just send them to the ER, bring them in every complaint they have.
Yeah.
Because it allows you to know what's real and what's not. So you don't want to be wrong in this as a physician. I don't want to be wrong. I don't want to
You can't miss something bad, but you can bring him
yeah, so
in
you
for
did the right thing. You
something.
said go to the emergency room, and she did not go to the emergency room. And often that will show you that nothing was actually happening. But it's always smartest to treat it like it's a real complaint. And then when it starts happening repeatedly, you just keep doing it. You just keep sending them to the ER if it sounds scary and it's not safe to wait till morning. If during the day, if they have a problem, have them come to the office during the day. And often it will kind of de-escalate that type of behavior because they don't want to come in that much. These patients, I'm not exactly sure what they're doing because I've had these patients too, but they don't want to come into the office is what I've
Yeah, it
learned.
sucks. No one
So
wants to go to the ER. No one wants to come to
no,
the
and so if
hospital.
you keep telling them, treat their concerns seriously and keep telling them to come in, all of a sudden that it kind of de-escalates that behavior and they don't do it. But not always, but often it does.
Yeah, and I think there's that population that they just are hyper concerned about something minor and they just need that extra reassurance. They need you to look at the
Right.
spot and tell them that it's fine. And that's okay. I still don't know what in the example that I gave, what that lady's motivation was. Like obviously she was lying on many levels and it's very bizarre.
Sometimes they're
Like,
mentally unwell. They're just patients that are unwell, and unfortunately, they've weaseled into our into our lives, and we have to help manage whatever's happening with them. But it's scary because I mean, getting a photo like that as a surgeon is really scary, especially when it's not expected from the type of procedure they have. I mean
yeah.
that is not a fun call. That is not a fun night. That is not a fun way to live as a surgeon.
Yeah. you're spending hours and hours worrying about this person
Right.
when they're sitting at home, probably watching TV, being like, I'm fine. I mean, so yeah, who knows? Again, it is a form of mental illness. I don't know what her specific diagnosis is, but probably some kind of personality disorder.
Yeah, it's very sad.
Yeah.
One of the most difficult patient populations are people that are upset about insurance billing and billing.
Ooh, yes.
This is probably, in all of our doctor groups, as you know, this is usually cited as the number one reason patients are unhappy and write negative reviews is insurance billing and financial things. And I think that it's no matter how well we explain things, people still don't believe us and they think they understand how things work. And it has the ability to destroy a fabulous relationship with your surgeon, all of this insurance and billing and all of that shenanigans.
I agree. I think you get more of that than I do because mine is literally like, okay, here's a proposed bill and what it is what it is.
It's hard because people don't understand how insurance works. I'll tell you, even someone who lives in this world, I don't always understand exactly how it works. The insurance companies too are horrific because as a patient, if you call, they tell you everything's covered, just
Yes.
trust, because they have no ability to know if anything is going to be covered for you as an individual. So I have patients call all the time and they say a tummy tuck will be covered for you. And then if it isn't, it's your fault. If I do a breast reconstruction and the insurance doesn't pay, they will tell the patient it's because we billed it wrong, which is objectively false. And it is one of the most difficult situations to manage because it makes patients lose trust in you as a surgeon when they think you are doing things to harm them financially. And that's one of the more difficult patient populations.
The other part with the billing is that any patient that spent any time on the phone with insurance companies knows that that is a huge consumer of time. So
Mm-hmm.
you'll have staff members spending inordinate amounts of time trying to get through insurance, trying to get prior authorizations, trying to figure out why things weren't covered, why prior authorizations were subsequently rejected and not approved. I mean, it can be a total nightmare. It's a lot of staff hours and therefore a lot of money for you to pay for said staff to work those hours, just trying to resolve those claims and those insurance issues. It's really difficult. So yeah, that is a big one. That is one nice thing about cosmetics is that we know what we charge and we know what the facility is going to be. We know what the anesthetic is going to cost, and there's
Well,
not a lot of
it's one of
unknown.
the reasons why my practice is out of network because it's such a terrible environment. We do the type of surgery where you want patients to have some insurance coverage because it's cancer reconstruction or breast reductions, but it's so toxic to deal with. We have just gone out of network for everything. And we have a billing department. I mean, just if anyone's listening, so they understand, like we have to employ a whole team of people just to bill for you.
Yeah.
I lose money, from what my fees would normally be to have someone help bill for you. That's how complicated the process is and how
Yeah,
much.
it's bad.
And it's the hardest thing about it is just that the insurers make it so difficult. And they also always put the blame on the doctors when it is objectively never our fault. Well, trust me, we would like to get paid. We turn those bills right away. We follow up on things. And it's just, I can see how they would be upset, but that tends to be a very upset, hostile, and especially when they don't understand and they weren't paying attention when they signed the forms and their idea of what certain things are didn't happen. It's very frustrating. If you have a breast reduction and your insurance sends you a letter saying it's covered, that doesn't mean it's free.
Sure.
And if you didn't pay attention when you signed the forms and you think it's free, when you find out it wasn't free, that's a very upsetting thing. So we've gone to having people pay upfront and then we reimburse them afterwards because of this issue. I mean, I just don't know how to get around some of the insurance things because they make it difficult. The verbiage is such that it leads people to be confused and like if something says it sounds like it should be covered, right? I mean, that makes sense to me. So yeah, it's a really repeated area of unhappy patients, unfortunately. And it's unfortunate because you damage really great relationships with patients that have great outcomes through no fault of your own. It's just the insurers.
Yeah, no, I agree. That's a big one. Insurance it's exhausting. It's so exhausting. And the other complaint about insurance is that you're not employed by the hospital
Right.
and say you were in network, The amount that they reimburse for in-network physicians makes it almost impossible to be not employed. So
that's creating an environment where very large corporations are taking over medicine, and private equity is taking over medicine. Everything's being taken over, not by individual doctors, and patients are going to be worse for it in the future.
yeah, when you have big corporations making medical decisions, which is kind of what has already happened in the insurance industry, but then when you have hospitals that are employing physicians making medical decisions, yeah,
Right.
it ends up not being beneficial to patient care for sure.
Yeah.
So,
And they see us as the leader of the team, so they think we have more power in this regard than we actually do, unfortunately.
or also that if I just write the right letter, that will get it approved. You know, all
Right.
I have
Yeah,
to
it
do is
doesn't work
just,
like that.
yeah.
If you say the right things, no, if I said the right things, you're right, I get it approved, but it's not true for you. So I can't say those things.
We can't falsify documentation.
Right. Insurance fraud. I had a patient very upset at me because I can't remember what it was. Oh, it was I think it was a breast lift was not covered by insurance, and she was upset, and she got the codes from the insurance company somehow that she believes should be covered, and I need to recode it. And the codes were cancer diagnosis. It was malignant neoplasm of the central portion of the breast. And I'm like, you do not, in fact, have cancer. You're right. If I did an oncoplastic reduction on you or an oncoplastic lift, it would, in fact, be covered. But you had a cosmetic breast lift. And the fact that the insurer would even suggest that to a patient with knowing nothing about, you can see how they create chaos for us.
Yeah, that's exhausting. Oh, I think another big category, and there's definitely some overlap, is just the total lack of compliance. The patients that choose to not do the set of recommendations that are put out by the surgeon. So that usually starts with preoperative things, but postoperatively as well. So it's not like we love to have you go get your blood drawn, and we just think it's great to have you have a specific clearance. We want to do that for the sole purpose of doing your case in the most safe
Right.
way possible, and make sure that we have minimized as many theoretical risks so that you have the best outcome as possible. Same thing with recommending smoking cessation. So people that, oh yeah, it's no problem if I quit smoking, but then they're coming back smelling like smoke and saying they don't smoke, that whole nightmare. Oh, either people that put on a bunch of weight or lose a bunch of weight around the time of surgery, that can be really challenging for your body. I've had some patients that will just think they'll gain like 10, 15 pounds before surgery because I'm just going to suction it all out.
Right.
Or some patients that decide to lose a bunch of weight right after surgery because they've seen some improvements already with their surgery, but they want to take it to the next level with additional weight loss. All of those things, even though it's spelled out very clearly preoperatively and postoperatively, that difference between the recommendations and what they're actually doing can lead to some pretty bad outcomes. So yeah, non-compliant
I
patients
think
are
it's
different.
hard too because patients have access to so much information right now. And I think sometimes too, when people have seen multiple consults and they've read multiple things online, they kind of forget what you as their surgeon have said, and they create this plan for themselves based off of piecemeal information. And it may not be the right plan for what they actually had done in the operating room. So on my social media, I have patients in my DMs nearly daily who have had surgery with another surgeon within a week or two and are asking me for recommendations on their post-op. And I had one today who's 2 weeks out from surgery, and she's asking me if she can not wear a bra one night. And I'm like, this is not a question for me. This is a question for the surgeon that operated on you. I have no idea what exactly was done to you. I don't know how you're healing. That is just, it's not safe for me to be giving you advice. But I think sometimes people are just hoping they ask enough people and someone will tell them what they want to hear. And you really have to go off of what your individual surgeon said for post-op care. You should follow their individual plan because they know what works in their hands. They know what they did in the operating room, and they know what they do to patients to get the best possible results long-term. So I think that just access to information can be kind of problematic too, unfortunately.
Yeah, I mean, I see a lot of those questions on Real Self where it'll be someone who's a week out, a couple
Right.
days, like, what do you look at this, look at that, what do you think? When those questions are obviously most appropriately directed to the surgeon. And usually that's what every person says, like, Okay, yeah, you're swollen, and you know, you need to talk to your surgeon because we don't know the details of what has happened. But that doesn't seem to stop people. I feel like that's one of the most popular things on
Well,
that
it
side.
cues you to that their relationship with their surgeon isn't healthy, because if they had a good relationship with their surgeon, they would ask them and then trust the answer. And the fact that they either didn't ask them or asked them and didn't trust the answer, it just shows that that relationship's not good. And that's a hard thing when it comes to cosmetic elective surgery. You as a patient have the ability to choose a surgeon that you do trust. It's not like going in with an appy and you just get whoever's on call and you're kind of forced into it. You have that ability as a patient, and we have that ability as surgeons to do our best to choose a good fit. So hopefully that stuff will be minimized.
Yeah, I agree. I don't get a lot of messages because I don't think I'm as active in social media as you are with regards to those particulars, like about like bras and random post-operative
Yeah,
questions. Sometimes those patients will actually come in for a consult, like
right.
1, 2, 3 weeks out, which kind of blows my mind, you know. It's
All the time. And I've had my patients do that to me in the past where, and they don't
bizarre.
tell me. And I remember once I had a patient who I thought I had a lovely relationship with, had a wonderful result, no issues. And I found out a year and a half later, she saw two of my colleagues at a month post-op because she had concerns. Never mentioned anything to me. I am an over communicator, as you know. Clearly, that patient did not trust me. And that's a bummer as a surgeon. I don't know.
Yeah, it stinks. The fact that you're seeing other people's patients means that, you know, odds are someone's seeing yours.
More patients, yeah.
So that's just the way it is. We talked a little bit about body dysmorphic disorder, which statistically represents about 1% of the population, but they are definitely overrepresented in plastic surgery.
Right.
So about 15% of people, which is, again, we're around that 1 out of 6 people coming in with body dysmorphic disorder. And what body dysmorphia means is that it's like a form of OCD. So it's on the OCD spectrum, just like hoarding is, where you're hyper focusing classically on one area, but it can be more than one areas. Feeling like that particular body part or body parts is negatively impacting your quality of life is grotesque. Everyone notices it. They see it. It's a big blemish and it's preventing you from doing all the things that you want to do.
And these patients are sad, I think, and they also are just misrepresented. Every time you see a post of Kim Kardashian looking different, everyone's in the comments talking about body dysmorphia. She does not have body dysmorphia. This is a real medical problem, a real psychiatric illness that people really suffer. And these are, when we had that body dysmorphia clinic come and talk, the clinical psychologist, they were saying these are the sad patients, and they're not hostile. They cry a lot. They want revisions. They don't even really know why. They just know it's wrong. They take a lot of time. And then they also have a very high suicide risk, which is really scary as a
Yeah.
clinician. I actually had a colleague who had one of these patients, and they had done one operation, unfortunately, and not recognized this. The patient wanted additional. They said no, and the patient completed suicide. And these are really sad patients that are really suffering, and it is the best thing you can do to not have them in your office. I've actually been referred one by a psychiatrist who told me to operate on her. So I think that sometimes even our psychiatry colleagues don't really completely understand how to manage these patients.
Yeah.
Surgery, not the management for these patients.
Yeah, it's interesting. There's different things in the literature about body dysmorphic disorder, and some papers talk about, okay, well, maybe half the people are okay with if you operate on them anyways, but the other patients, like what happened, you're worsening their disorder, I suspect. So
Right.
it would be a roll of the dice to knowingly operate on someone who has that much of an issue, because the truth is, you know, if one of your flanks is too full and you can't leave your house and you can't get a job and you can't get married and you can't go on vacation.
You try
That
12 outfits on a day to try to hide it. Um,
yeah,
you spend 3 hours doing lymphatic massage a day. If you spend an inordinate amount of time trying to disguise the area, if your nose isn't the way you want and you spend 2 hours a day doing contouring,
contouring.
adjusting your contouring and checking in the mirror, like those are all some of the warning signs that you see for body dysmorphia.
Yeah.
Um, we had a very obvious one in our fellowship. I don't know if you remember, but she had, by the time I saw her, she had probably 6 surgeries, and she was 21, beautiful girl. It was very,
Oh yeah, like the cheeks.
yeah.
We put in implants, took them out.
Put in implants, took it out. She had a brow lift, a repeat brow lift. She had a
Like
rhinoplasty,
multiple rhinoplasties.
right?
I do know who you're talking about.
Yeah,
Yeah.
it
She's
made me,
gorgeous, but she
she's
didn't any of that.
gorgeous. She was gorgeous. Like, I mean, like one of those people you walk in the room and you're like, oh my God, she's such a pretty girl. It was so sad. That was my first like one that I really recognized was body dysmorphic. And I was like, oh man, this poor girl.
Some people are, again, better hiding their issues than others. And sometimes they won't tell you about other surgeries. And sometimes you can, you can see scars
Right.
and figure it out. And people won't tell you about those kinds of things, but other times you can figure it out. I remember I had a patient not that long ago who I just did some liposuction and some body tied on. And some of it was just like a single revision, like she had had it done elsewhere. And I remember seeing her at her 2-week appointment, and she was saying how she couldn't wear any of her clothes. She only could wear her shorts from Walmart that had holes in them. And all she
Right.
did all day was just grab the fat parts of her body and cry.
Sad.
And yeah, and she said that she was supposed to go on vacation. She had to cancel it because she wasn't going to be able to, in like 3 months from then. And she didn't think she was going to be able to get married because she wasn't going to fit in her dress. Putting a lot of your happiness and what you're going to do with your life with, I don't know, the shape of her abdomen or whatever it was. A lot of these cases, like there are some subjective and objective improvements,
Right.
but the problem is that they can't see it.
Yeah.
And
They
even
don't
if
see it.
they don't see the improvements, and they are still just as displeased with that particular body part or body parts as they were prior to surgery. Now they're still displeased. They've spent a fair amount of money and they're sore and they're tired and their life isn't any better. So they can be really difficult patients because for a fair amount of them, no matter what you do, they're never pleased. But that, like I said, I've seen some articles in literature that say, okay, well, like a subsection of patients like actually benefit from it. So I don't know. I mean,
I wouldn't touch one with 10. It's not worth it to me. There's no way to know if you are going to see the patient that would improve. And you could potentially really harm them, like my friend's patient. So I no interest in getting involved in something that could harm a patient like that.
I think the other subsection or the other group of patients that is just classically difficult are those patients that have some kind of mental illness. So patients that are depressed, and that's about 10% of people. Patients that are anxious, and that's like 20% of adults. Bipolar disorder represents 2% of people.
Right.
Schizophrenia is 1% of people. So when you add all those numbers together, it ends up being a huge portion of your potential patient population that suffers from some kind of psychological or psychiatric diagnosis. And
Right.
those diagnoses make them a more challenging patient to care for and treat. Obviously, some diagnoses more so than others, but
Yeah, I learned some things actually from one of our attendings in Oregon when we were a fellow. Ladizinski was really good at talking to patients about mental health. And I think it's awkward and a lot of us don't know how to do it, but the things that he would ask a patient, I talked to him about it one day and because I saw him doing it repeatedly, is he would always ask patients that were on psychiatric medications, how long have you been on this med and how often have you had the dosage changed? Because that will give you a hint into how stable their mental health is on that particular medication. And then he would also ask them, do you feel that your anxiety is well controlled on this medication? How is your mental foundation? Do you feel it's stable right now? And patients are actually really honest if you ask them that question. I was always surprised. We would have patients go, no, I'm not doing well. My depression's not well controlled. And I think that sometimes just being blunt, but with kindness in your voice is all you need to do to get really important questions answered. And it doesn't mean that patient's never going to have surgery, but it just means maybe not today.
yeah, and the truth is that having surgery is a stressor, right?
Absolutely.
So if you have depression, if you have anxiety, if you have any kind of other mental health issue, expect a flare in that issue. Expect it to be exacerbated because you're stressing your body or stressing your mind by having something done. And so, yeah, I think you're right. Being blunt, being upfront with someone, be like, look, I see you take this medication. Are things stable? Are they well controlled? Because if no, we're going to probably make it
Make
worse.
it worse. Yeah, we definitely could make it worse. And, all of these medications we give you around the time of surgery just allow your mind to go haywire, even in the best of circumstances. And if you are already having trouble with your mental illness, I am going to make it worse with surgery.
Oh, yeah, for sure. The schizophrenic patients, which again is like 1 out of 100 people. They're difficult because they usually don't tell you. I mean, I
Right.
don't think I've ever had a schizophrenic patient tell me that they're schizophrenic.
Yeah.
I think there's always a compliance issue with that patient population. I actually had a run-in with a patient and the police where a patient with schizophrenia of mine who I didn't know had schizophrenia until postoperatively ended up at in a high-speed car chase that ended in my office.
Oh my God.
He parked in front of my office and thought I was going to save him. He was delusional and thought the police were
Oh,
devils
okay.
and jumped out, was like driving fast, driving around school buses, drove to my office. Like, I'm going to save him. And, jumped out of his car and ran into my office, like screaming my name. And it scared everyone, because
Of course. Yeah. I mean, that's terrifying.
yeah, it's terrifying. Those patients they don't tell you they have those health issues because they're worried you're not going to take them on as a patient. So there's a lot of lies of omission in this field. And probably not just plastic surgery, probably in lots of other medical fields, but where people they realize that this diagnosis is a really challenging one and they're motivated to do something and they're concerned that that is going to be something that will prohibit them from getting what they want,
Right.
which is like, again, there's probably some truth to that, but it certainly makes it really hard as the physician who's trying to care for said person to have a really good plan for them because you don't know all the pieces of the information. Like, what's their social support like?
Mm-hmm.
All of those things that are helpful to ensure that a person is mentally stable. If you don't know that they're having these issues, you're not going to do the same kind of investigative line of questioning that would help you determine if they're a good candidate.
Yeah, absolutely. So it just always comes back down to, having a good open relationship, both patient and doctor, really prevents a lot of the problems we're talking about. And we're all limited when people aren't honest with us or about all kinds of things, their mental health history, what their expectations are, what's actually going on in their life. I think our position is more than just a technician. A true great surgeon really dives into all of these things with their patient. And sometimes even when you're very good at this, things get missed and you end up with patients that torment your office and make it really rough for you.
Yeah. 1 out of 6 times. No, I don't think that high.
I don't know, I don't think it's that common either. But yeah, the ones that are difficult certainly are the ones that take a lot of your thought time, and which is unfortunate because we have so many wonderful patients. They really should be the front of our mind. But at 3 a.m. when you wake up, it's never the kind, lovely ones that tell you they changed their life that you think about.
Yeah, this is true. And obviously, even in that difficult patient population, there are some that are more difficult than others, for sure.
Sure.
So, as a rule of thumb, I think as surgeons, as physicians, our goal is to help people figure out whether it's aesthetic or reconstructive, what it is that their goals are, what would be a reasonable expectation to achieve, is what they're wanting, something that we can deliver, right? And off the bat, if those aren't in alignment, that's not going to be a good candidate. We want to make sure that they are medically healthy enough to undergo this procedure because, again, looking good in the casket doesn't serve anyone well. And we want to make sure that postoperatively they have the mental faculties and the social support network that's going to let them heal well and
Absolutely.
do surgery. So all of those things are super important. I think in training the difficult patient, it's not something that we spend a lot of time talking about. And most of my understanding of these kinds of patients is probably just more from real world experience. I mean, we see those patients in training, but I think that there's that extra layer of protection, meaning like we're not,
You're
when it comes
shielded
down to
somewhat
it,
for
yeah,
sure.
for patients and or prospective surgeons, honesty is super important. Being forthcoming with your medical history, whether or not you think it's going to be something that is a deterrent for your surgeon or not, is super important as well. And I think if you don't know if that patient is a good fit or not, I would say like go, or your surgeon for that matter, trust your instinct. You just have to go with your gut, and sometimes you're wrong.
But hopefully most of the time you're not, and you have great relationships. But yeah, it's definitely something that is one of the reasons why doctors have burnout and difficult times. So like you said, you just got to learn to recognize the warning signs and the type of patient that doesn't do well with you personally.
Yeah, exactly. Well, that's about all I have for difficult patients.
Sounds good.
I would like to decrease my number from one to, well, let's see, one. I think I'm 1 out of 8 or 1 out of 9. But hey, if I could get it even lower, the better. Because the patients, the easy patients, they come in, they want to do this or that. You
Mm-hmm.
evaluate them. You're like, okay, I can do that. They have that done. It's a good outcome and they're happy and they thank you and you high five. And that's not the end of a relationship, but that's kind of the crux of it. But those aren't the patients that stick out in your mind. And those
Nope.
aren't the patients that keep you awake at night, worrying, wondering, like, what did I miss? What could I have done differently? You can only make decisions based on the facts that are at hand. And so you're going to miss things and so you're going to have difficult patients.
Sure
Period.
are. So try to minimize it, and we all can commiserate together.
All right. Well, thanks, Kelly.
Thank you.
Have a good night.